the ground rules today. I'd like to welcome everyone to our first, I'll call it KHS branded webinar of 2025. I know there's several other webinars that we will be a part of or have been a part of. But it's great to see the number of attendees or registrants that we had for today's webinar, as well as seeing those that are in attendance today. So it's great to see many of you that we know, and it's also nice to see those that may be joining us for the first time. And I'll steal from Mike in that there are no strangers in quality, just friends we haven't met. So if you're new to KHS and to us, welcome, and we look forward to getting to know you. We all know it's a small little world that we operate in healthcare quality. So it's been a fun journey, closing out officially what is 9 years. Believe it or not, this March is 2016 is when KHS was founded. And so it's really been great, and to have the timing of this and some of the other things, and attending RISE conferences and other conferences that are coming up. So happy to be here and kind of report as we go into this phase of Kaiser Healthcare Solutions and really building, those new relationships and with people like Don Lee here and Michael Campbell. I will say, since my return from CMS a little over a year ago, we've really put together a good, strong leadership team, and we've spent a lot of that time over the last year, like really blowing things out with KHS and our core client base, which is primarily health plans and payers in the HEDIS space. And that commitment's really paying off, and I'm happy to be here with the growth and success that we've had and continue to do that. And our success is based on our client success. And so we recognize that, and we appreciate all our clients that have given these opportunities to work with them. All right, so to kind of go over just high level, I won't go into details on each of these. I encourage folks to follow up with Mike Curran, our principal of Payer Solutions, to go deeper into this, but just a little more perspective. A little over half of our, or maybe a little bit more than a little over half of our business and foundation of KHS, as I mentioned, is around working with health plans and supporting those and shifting to a value-based healthcare delivery system. And these items here focus towards that health plan client base. I know there's many others from some of our other client bases and areas. I'm glad that you are joining, since we are talking about digital quality measures. And in those worlds, it might be called, or part of dQMs, ECDS, or electronic clinical quality measures. But the products and services that we're talking about today, and the primary focus will be looking at the HEDIS use case for health plans. But I'm sure there'll be plenty of other informative bits of information that come from Don and from Michael that are pertinent to all of us across the quality measure landscape. So just to set some objectives for today, really we're focusing on what I see as the evolution of health plan quality measurement, I guess quality measurement as well, and advancing that to the 21st century. A lot of measurement has been really not too different than the way quality measurement began in the form of HEDIS 1.0 or 2.0 in the 90s, and now definitely making that critical move or momentum into what I call the 21st century. I know we've been in the 21st century for 25 years now, but we know how healthcare can be a little slower to adopt and advance, but happy to see, the work of the last 5 years and how there's some tipping points and things are moving forward here. And really want to call out and applaud the leading efforts that have been coming out of NCQA, CMS, HL7, and many others that have been driving forward and getting to this new paradigm. Just a couple of things too, are kind of things from my perspective. There's a fair amount of uncertainty, I think, that always goes on in healthcare and where things are going. I know there's a lot of uncertainty that's going on right now. We have changes of administrations, and there's a lot of changes that are going on today. I'm not going to get into those pieces, but I will say this, and part of this is based on when I came into CMS, it was at the beginning of the Biden administration. So I was there while things were coming on, and there was a lot of the SEMA-VERMA policies and priorities that were still underway until the new administration came in, and Shakita LaSure Brooks joined and had her set, or the Biden set of policies there. And there's a lot of great work, and there continue to be a lot of great work in really advancing things. But I will say this, with all the uncertainty that's going on and concerns that are out there, like where are we going? I am very optimistic that the current administration, and I'm not endorsing any politics or any administrations here, but I'm pretty optimistic the policies will bring this back to that forefront, or to the forefront, and getting back to the things that are looking at or focusing, reducing burden, inefficiency, and helping to really reduce waste from our healthcare delivery system. So that's one thing I remain positive about and optimistic about. And all of this really revolves around the understanding of fire and fire standards, and that becoming the new, I guess, de facto, or maybe more than that, standard for uh, the data that we're looking to use for healthcare and interoperability, and really improving that data exchange to really at the core of it, to improve that accuracy, timeliness, reliability, so that we're all able to report the best results that improve quality and deliver higher value. I'm also a big believer that the enterprise level strategies and collaboration, it does need to change before we can get to the point of full scale fire CQL, or clinical quality language DQMs, digital quality measures. And historically, as we know, and I personally experienced, and many others here, quality teams at health plans have been historically low on that list of priorities. And that's what we're here for, is to help and navigate those waters and have those messages to take through as well. So, have no fear. This is why we started KHS, and really a lot of our strength. And like I said, it really comes down to our experience in understanding this firsthand on the job and understanding those pressures. And finally, we'd love to have you leave today, thinking and asking, what about your organization? What does your organization need to do to prepare or continue to build upon that journey and that roadmap? And I do ask you to follow up with us, to go deeper with you in understanding your concerns with the needs that you need to have adapt and evolve rapidly with the significant regulatory and compliance changes there. So, I'm not gonna, this isn't a sales presentation, but I will say we highly encourage and it would appreciate follow up. And I think you'll learn a lot just from a brief conversation with us, and determining if there's something that we can help you in your organization with. So let that be known and said. Also, as we go through, like I said, the first webinar, we're here to help develop content that helps you get the movement in your organization. Like I said, at the decision maker levels. So let us know, what you'd like to see in future webinars, content. We definitely probably could spend 3 days with these gentlemen today, just going into a lot of things. They're gonna have a challenging time with the 5 minutes I'm gonna give them to respond to each of the questions. But there's a lot more to go into, and we certainly can go deeper on today's conversation or other areas that the audience would see to be useful and helpful, just from a thought leadership perspective. All right. Well, without going through all the details here and just jumping into the content, our panel of experts here, I'm just going to briefly introduce them, not by the brief bios that are here. You can do that, or go to LinkedIn or other places. But really, I'm going to introduce these are folks and how I met them. So I'll start with Don, since he's here on the left. My first interaction with Don Lee is that I sat on the other side of this microphone from him, being interviewed by him on the CAQH Index, and for his podcast many years ago. And I've been following him ever since in that. And we've, over the years, just, I'll say, run into each other randomly at different conferences, no planned intent, but run into each other, and it's been fun, just naturally, birds of a feather type of thing, bumping into each other at things that I never would have thought of or maybe expected we would see each other at them. So it's great to be able to continue, our relationship, and bring, Don forward here as one of our thought leaders. And then there's Michael Campbell, going back to that 20th century reference. Michael and I, back to 1999, when I started at NCQA, I was the manager of the HEDIS data collection. He was the manager of the audit program, and one of the architects behind developing the software certification program. So we worked closely together there, as well as Mike Current, actually, at that point in time. And I've sat on the opposite side of many audits with Michael over the year in my days at United Healthcare. So it's been fun to be on that side. Not only was working with him, but working on, the other side as a health plan being audited. And same thing like Don. Continue to run into him at various conferences. It was great to reconnect with him a few years ago, just at HL7. So it's been great to reconnect with Michael, even though some have been following him just through the audit community over the years. And really, yeah, it's great to have him here as well as one of our panelist experts here. And I'm really excited also to see him partnering up with Michael Klotz over at VLOX. I know they're working on some pretty cool stuff. And then I won't introduce myself, but I'm just the guy that's coordinating all of this fun here today. So thank you. All right, I really want to jump into the content. We're right on time. And just quickly on this, this is one of those ones I would say when we do meet and follow up, this is something we would love to pull up in front of you and kind of go into more detail here. But if you just look at the bullet points on the right, that's what I would say is the takeaway or the lead for today. And without going through all the nuts and bolts of this and getting to the content, I will leave it there. And one other thing, just kind of recognizing there are what we see, and it's at least 5 challenges, but the key ones that we see and that the things that I really want to, or that I see is, are they concerns? They're definitely challenges. Can they be overcome? I think so. But do we have to recognize, like, there are some significant challenges that are out there. Things are moving forward. They're moving away from medical record, hybrid specified measures to more ECDS, which will eventually move into the full FHIR CQL dQMs. But this just gives you kind of an idea of what we see as some of those 5 major challenges to achieving full digital quality measurement. And ultimately, it'd be great to see something that gets closer to a learning health system. So with that, let's jump right in with the first question. And we'll start with Don. So Don, interoperability in the healthcare system has seen, advancements in the past decade. What do you see has contributed to that increased acceptance and building upon those challenges? What are the greatest challenges you see that are lying ahead of us?
Yeah, great to be here. Thanks for the question. Really important question. And one, I like to take a step back even a little bit farther than that when I think about where we are in healthcare interoperability and what our challenges are, where we're going. So the first thing I want you all to think about is, why does an industry go electronic in the first place? Why does an industry digitize? And most times an industry digitizes because it's good for business. It makes them more efficient. It saves them money. It makes them more competitive. It allows them to do things they couldn't do before. And that didn't happen in healthcare. So around 2009, the government had to step in and say, like, it's time and the incentives don't exist. So we're going to do that. And they put up the $27 billion coming out of the High Tech Act. And they said, we're going digital. That, of course, got a lot of people moving, right? $27 billion brings everybody to the table. EMR vendors sprung out of every corner of the universe, came up and, had solutions. We're gonna solve this problem for us. And by and large, it worked, right? Not by and large, it completely worked. The entire industry went digital from like 0 to 60 and in almost no time at all. When you really think about it on the scale of things, we went from no adoption in hospitals to ubiquitous adoption in hospitals. Everything was digital into, we're in like the 2013, 2014 timeline. By then it was pretty much done in terms of the initial rollout. So that's when we started doing stuff. We said, all right, we've got all of this data together. What can we do with it? Let's start solving some problems. And we found out we couldn't. And people started saying, well, wait a second, what happened to the $27 billion, right? Like what did we buy with that? And it turns out we bought exactly what we asked for, right? Like if you look at the early versions of Meaningful Use, it was all about just getting the systems in place, very, very rudimentary interoperability. Like, can you send one record to one place? Like almost nothing. And people were implementing it that way, right? They were implementing it to satisfy the checkbox, not to solve business problems. And that's where we were. So in that time, again, everyone's screaming and hollering, where's our $27 billion? We got hosed here. Every other industry under the sun's figured this out. And like that part of it's just not true. And that's like a key point I want to make here in this run up, as people look and say, well, banking's figured this out, manufacturing's figured this out, and they have for use cases. So the example I like to give is ACH, right? You want to send money to somebody in the bank. That's like, it's going to work. It's easy. Everyone does it. Boom. It's like, it's just a no brainer, but that is a single use case that is implemented with a text delimited pipe file that gets sent over FTP to a place. And if you screw it up, you get kicked out of the program. So like that use case works well because it's a very simple problem, it's a very simple implementation, and it's a very bad consequence for you as a vendor if you get kicked out of the program. So it works, right? So, but if you look across the financial industry, solving that use case doesn't mean the financial industry is interoperable. Think about what you're all going through right now for tax season. Is that interoperable? Think how much work goes into that. A whole industry built around collecting data out of many systems, scrubbing it, making it all make sense, and then setting it up to the IRS into a different system, right? That's what we're doing in healthcare. So over the course of the last 10, 15 years, from that point where we realized that we didn't buy interoperability yet, we started working on it. And the use cases started coming in. We started solving problems for ACOs, quality measures came in, real e-prescriptions, right? Solved use case. I'd say prescriptions would be like our ACH. You know it works, everybody's on it, it's a solved problem. But we have bigger problems. And I think over the course of the last 10 years, we've continued to take bites out of those problems and put things in place to help us work on them. And that's where you start seeing national networks spring up. Not perfect, but Care Quality, Commonwealth, eHealth Network, they all solve problems. They're all good at things. They don't make ubiquitous interoperability, but they solve problems. So bottom line is, it turned out that this was really, really hard. We have a really complex data set. We have immensely challenging data quality problems, and we have an industry that believes that this is easy and should have been solved 10 years ago, which breeds a lot of impatience and favoring of like the silver bullet solutions that are supposed to fix everything today instead of taking our time to do it right. So that's really what's been happening over the course of the last 10, 15 years is while we have these big shots trying to solve the whole problem that we can't even define, we are making progress on use cases, and we're making really good progress as we go along. And we've got a lot to build on as we move forward. And then I know the last part, biggest hurdles here, I kind of already touched on all of them, is number one, what are your clearly defined use cases? What specific problem are you trying to solve? You don't go get all of the data. You don't want all of the data. That's a pain in the butt and it's expensive, but you can get the data you need to solve this use case. What is data quality? That's kind of the next problem. Once you define what you get it. Data quality is an issue. And then that impatience that I talked of, that kind of leads to the desire for silver bullet. And I get it, but that's a problem.
Yeah. No, that's great. And just, I mean, you're right. You're spot on. Like healthcare and healthcare data is extremely complex, complicated, maybe sometimes convoluted. And yeah, it's really kind of a stepwise process in getting through and to your point, really breaking it down to what you can manage, one piece at a time and build upon that. So great insights there, Don. Appreciate that. Let me go to the next question to Michael, and I just want to make sure my slide advancer. There we go. So, Michael, are there things that U.S. health plans should be or could be doing to increase the progress of health data interoperability across the healthcare delivery ecosystem? I know this is something that you've been very passionate about.
Yes, actually, I don't know. Well, passion, I suppose. I think that's a blessing of being liking what I do, and I think combining what my personal interests, my professional interests are. Personal being just someone who probably leans towards OCD. I like things organized. I don't like to waste time. I like to get to the point. I like to respect everybody's efforts and make sure that they're leveraged in the most efficient way. I would say, and it's something that we do quite often actually, as we're talking with plans. It's something I was actually doing it during my audit days. I am retired as an auditor now, but that's also partly so that I could really liberate myself of any potential conflict of interest and really start to get into solutions. And this is exactly what Reed and Don and Michael and the team at Velox, which includes, as Reed noted, Michael Klotz, who's the CEO and chief consultant for a number of years at NCQA on its digital measure strategy, but also Rick Moore and Michael Barr, Dr. Michael Barr. So all of us have been thinking and looking and observing and participating and engaging on digital quality measure development. And so the things that I've been focused on now with clients are things that you need to do now for the use cases you have now, including HEDIS. We're not trying to simply ignore the demands on your time, what you need to leverage for resources now to do something for the future. What we've been trying to do at Velox is combine a platform that solves real world problems now, but also gives you a nice, well-lit, milestone-driven runway to get to that endpoint of digital measure reporting. So I think what we've observed is plans that are successfully doing this have a couple of key components. And one of them is they have a champion within the organization that is prepared to learn and understand what the challenges are, understand what the resources that are needed, both from a human resources, finance, and technology, and are willing to help to guide it through kind of what we'll observe with any situation with the organization going through change. There's resistance. We all naturally resist change, some more than others. And so having that individual there who recognizes, kind of sees the big picture, can put that strategy to operation is really important. And this is something that KHS is doing. I assume that Don is doing this, especially with his work through the data validation program through NCQA. I think there's an underemphasis in healthcare in particular on the importance of data governance. And I think we mentioned in particular, Don did it, healthcare, we have a very, very complex data model. And I want to give ourselves some allowances that we have to adjust our timeline for when we implement this migration to digital exchange and the digitalization, if you will, of our environments, is that we have that complex model. But we're not selling widgets. We're not selling vintage Adidas sneakers. We are selling healthcare services, and people's life, not livelihood only, but life really is dependent on that. So I really cannot implore you enough to try to get a handle on your data governance. There's a lot of different frameworks. There's consultants, of course, that can help you put that into place. But I think that's one of the key things that has to be done regardless of the use case we're talking about. And I'm sad to say that a lot of the work I did with clients over the years show that really wasn't a priority. So I really compel you to try to make sure that's a priority. One of the key building blocks of any data governance strategy is to have a comprehensive inventory of all of your data sources, or we'll say use case specific, ideally everything in enterprise data management. But you can start with a specific use case. And we feel strongly that the most important one, for two reasons, is building your inventory for your HEDIS reporting.
Right.
One is because it's a requirement. To have a comprehensive source, a listing with the metadata that supports it of your administrative and clinical data sources. And I would say the other one is because from that, you can start to then build the complexity and capture additional data that you need to really sort out where you are. If you're going to have a strategy to move forward, you don't know where to go if you don't know where you are. And that's what an inventory is really very effective at doing, is without capturing PHI, you just simply have a collection of the metadata. And you can use that metadata, and I'll say it from the auditor perspective, but fortunately it really aligns as well with what Michael Klotz was doing with scoring data channels. So let's look at this landscape of data we have, but they're not all equal. Some have high complexity. There's manual abstraction. There's sometimes months or over a year of latency before we get the data. Sometimes there's a lot of mapping. We don't see a lot of proprietary codes anymore, but they still sneak in there. And there's a lot of EHR vendors that love their little proprietary codes that have to be mapped. Every one of those examples is just another means by which you're increasing the friction and the risk point from an auditor perspective of those particular channels. Those will, especially if they affect a lot of your plans or your population, or they have a lot of use cases that they impact, those will bubble to the top is the channels that you want to focus on. Can I potentially replace this channel? Maybe I go from a custom data feed to a CCD data feed. Great, that's moving in the right direction, moving towards standardization. Ultimately, of course, and part of the reason that you have now more experience with, or see individuals with more experience with FHIR, is that's kind of like, that's the Valhalla. That's where we're moving towards, is an open source standard that can be easily shared. And then we can then layer on top of that things like the CQL engine that we can run. So inventory is really important. And then finally, I think it's important to start really paying attention to, and this is going to be very HEDIS specific. We are moving from HEDIS, and then a subset of that is hybrid HEDIS, to ECDS. And when we move from that hybrid to an ECDS like we're seeing with CIS, IMA, and CCS, I assume you guys know the acronyms if you're in the space. If not, we'll
Yeah.
provide those later.
Yeah.
That you will start to see a drop off in those numbers. You have to have a strategy. How are you going to fill that gap in clinical data when you're not able to rely on a sample-based population, but yet now the entire population? So there has to be strategy around that. And that's an area as well that we've taken a lot of forethought on at Velox and the platform, is to help you track those differentials. And then the ultimate one, as Reed noted many times earlier, is getting from ECDS. It's almost like the natural gas transition fuel to get to, say, green energy. Then we get to dQM. So having a strategy that you can track with metrics that support that, KPIs, et cetera, are really essential. Three things that I think every plan should be doing.
No, that's very informative and insightful. And yes, definitely a lot more pieces we can go deeper in on that, and
Right.
happy to do that. So appreciate that, Michael. All right, okay. So I think you kind of built on some of the things. I mean, going towards like open standards. So why don't you start on this one, Michael, and Don, you can weigh in as well. But how has FHIR become the interoperability standard in healthcare, and what should health plans be doing to increase adoption and use across their provider networks?
Yeah, I do have a lot of thoughts about. I'll try to keep it succinct, but I kind of preface it with this statement. I haven't heard it yet, probably because I've been talking about FHIR with clients since about 2020. That people know that if they were to say to me, "Oh, FHIR, it's just a fad, it'll go away," that my head would blow up, because I've been, really deep into the weeds with it. And the reason part of it would probably blow up is because, well, three key points I want people to understand about it being a standard. And I mentioned earlier it's an open source standard. I'll layer in the fact that it's actually a free open source standard. That removes a tremendous amount of friction. But it actually has, definitionally, it has three types of standards that it qualifies for. And one of them is a de facto standard. Many of us are using software and we talk about sending a file. I don't have to explain to you, please send it to me as a Word document. We just know if you send me a document that's of that type, that I can open it in Word. Same with Excel, etc. So in that manner, FHIR is a de facto standard, meaning that it's informal in the sense that it's been adopted through convention, it's been adopted for widespread acceptance. And let me give you some evidence of that, as well as how fast it's growing. Right now, there was a FHIR lead, which is a partner as well of NCQA and their dQM project. It has been growing since 2023 at 25% a year in usage amongst EHR vendors. If you look at actually the adoption of it in a mandate or some, say, integration requirement in the government or private industry, it's actually been increasing since 80% a year from 23 to 24. Small number, grows quickly from a percentage point, but that rate is happening. It's not just the US as well. And that's another thing I want to emphasize, is that there are FHIR conferences going on all over the world. And by last count, that's approximately between 40 and 50 countries and multiple continents that are rolled into that. This is Australia, this is South America, North America, Europe, Asia, everywhere. It's been very widely adopted, again, partly because it is free. Yeah. Another thing, it's a formal standard, which means that as it's been mentioned before here today, it's HL7. HL7 is the standards development organization that's been recognized and accredited by ANSI as the SDO, which is responsible for the stewardship of FHIR. And there's a whole lot of work that goes into it. There's governance, there's work groups, there's a real structure that's in place, like NCQA has to follow, for example, with their HEDIS measures, that are responsible for maintaining it. Yeah. So that creates form. And then finally, it's a du jour standard, which is simply means that it's been implemented by mandate. That, as we mentioned, the 21st Century Cures Act, other state regulations are also requiring it, that is mandated to use FHIR. So those all add up together to make a very convincing case, whether you believe it or not, it's here, and it will be the interoperability standard for healthcare.
Yeah. Yeah. Let me transition this over to Don, and I'm actually going to roll this into the next question. And Don, they're somewhat related, so feel free to sprinkle in together there. But Don, what do you see as the greatest barriers to full adoption of FHIR? And, what are the three things or so that, they should be doing or plans should be doing to ensure that success as we move to the digital quality measures in the HEDIS reporting paradigm?
Yeah, absolutely. And what I would say is that FHIR 100% I'm with Michael. Like it is the way. It's the way forward. It is the standard. It's going to be the way things are done in the future. But I also, whenever I talk about fire, I like to make sure that we're thinking about what it is and what it isn't. And it is a more modern technical way to solve problems over by sending data over the internet. It's a more modern API structure. It's like everything about it works like you would find in any other industry, and it kind of grew grassroots up and has been adopted into the industry and has slowly but surely been adopted by the government and everything else as well. So it's like it is a better technical way to solve the problems that we're trying to solve, and that was some of them that we've already solved. But it's not magic either, right? So I think the number one biggest adoption for fire, and you'll see a theme here with me on stuff, is I'm always looking for like, watch out for any kind of silver bullet talk, watch out for any kind of magic talk. There's a lot of magic talk around fire, and people think that once fire is adopted, everything's going to be solved. And we'll finally be at that place that we thought we should have been with after the $27 billion back in 2014. And that's just not true, right? So if you had data quality problems in your CCDAs, you're still going to have data quality problems in your Fire APIs. Like it's better. It allows us to do things we couldn't do before. It allows us to bring people in from other industries that we couldn't. But it's not magic, and it's not going to just solve all these problems. So biggest hurdle number one is that silver bullet thinking again that'll keep cropping up whenever you talk to me. It is, and number two is the things that are already working, right? So in my mind, it's not a bad thing that it's taking us a long time to implement fire because there's things that are working really well. And when they're things are working really well and other things are not, well, you leave the things that are working alone, right? So we do a lot of good stuff, wonderful things with ADTs, HL7V2s to, for alerts and notifications when people end up in the hospital. Wonderful stuff. We could do them better in fire. We could do things with fire, but we don't need to rip that out and replace it. We got a lot of that right. There's some great things that have been done with CCDAs in terms of getting quality measures together, everything else. We can let a lot of that ride. So the existence of working solutions is definitely a hindrance to the adoption of fire, but and a big one, but I don't see that necessarily as a bad thing. So if we can kind of just, get away from the silver bullet thinking, think about, well, which unsolved problems are best addressed with fire and direct our energies towards those and apply it there. The rest of that stuff will come along when it makes sense to, right? We don't have to force it. The businesses will decide when it makes sense to, and it'll happen. So that's like the combination answer would be, for what we should do and what the hurdles are.
Yeah, so let me go to the next question here, Don. I'm going to continue with you. Just, I know over the years, some of the things we've crossed paths around health information exchange. But what are the things you see that could be doing to increase access to clinical data sources? I know you touched on some of this as well, but just kind of thinking globally, beyond EMR, HIEs, other data sources.
Yeah, first thing I like to think about here is separate your near-term needs from your long-term vision, right? Like they're two very different problems, and you should try to address them separately. I see a lot of organizations try to solve the long-term problem thinking it's going to help them right now, and it never works out, right? So separate those two things. First, take your short-term problems, the things you need data for right now. Let's say your stars are going down for a particular measure. Is there data out there that can make that better? How do you find out? Who can you work with? It'd be very specific about the problem you're trying to solve. Like we think that, our stars went down or this measure is lower than it should be, and we think it's inaccurate because of the data. We are missing data. We want to go out into the community and find it. Find those sources, right? Are there HIEs in your neighborhood and your community that are good, right? Across the country, there's some very good HIE markets. And if you are in one of those spaces, you're lucky and you should take advantage. Go to the HIE, find out if they can get you large amounts of data and to start attacking that problem. If they're DAV certified, that could be a plus when you're in the HEDIS world. Michael mentioned that earlier, the NCQA program. It's basically like a pre-audit. So if you can get the data from an HIE that is DAV certified or an aggregator that's DAV certified, that might make it a little bit easier for you to work with. So beyond that, right? Like if you're not in a good HIE market or you don't get anything, can't get everything from them, look, who are your big partners? What are the other sources? And you've got to be flexible here. Again, you're thinking short term. You're not trying to build the perfect solution to your long-term problems. You're just trying to address this issue today so that you stop getting penalized or losing money or whatever the case may be.
Yep.
So that's your, do that on the short term. And this will apply to both short term and long term, but I'll put it here because it's more timely, is be easy to work with too, right? Like think about like,
That's key. Yeah.
are your processes making it difficult for people to help you, right? Does your security assessment take 6 months? Does your legal review take 3 months? Does your, is your technical team too stringent on what they will work with? Like think about those things. Again, short term. This is not, if you make this decision now to take something that's not what the tech team wants in the long run, that's not bad because it's just for now we're solving the problem now. Then you can shift to your long-term stuff, and that's where you can, paint your beautiful vision. That's where you can like say, 5 years from now, what do we want to be doing? Fire should be a big part of that, right? That's where you think about like broad strokes. How does fire apply? How does it help us do this vision? And then who are the people we can work with, right? Build your collaborators. There's maybe somebody in your local region that you're already working with that's interested in doing some R&D type stuff, looking into the future. Work with them. Go get involved in the fire community. Fantastic national community, as Michael already alluded to. Fire Dev Days is one of my favorite conferences I've ever been to. It's so
Right.
fun.
Yep.
Very dev. That would be send
Yep.
your devs there,
Yep.
but super fun. Participate in Da Vinci Project, right? That's where they're getting industry people together to solve real problems. Like how do we do prior authorization better? That's the vision stuff. That's
Yep.
the long term. That's where you really want to be tying your fire stuff in.
Yeah, and you hit on a point there. This is off the cuff too, but one of the things that I think that's been very beneficial is for me, where I know enough generally about are around these things, but I'm not going to go super deep into. I'm not going to be a CQL programmer or anything like that. I can read it, but I'm not going to program it. But one of the messages I had is when I was at CMS, and I know my final presentation that I gave was, just get exposure. And you mentioned HL7 Dev Days, even what are they, not hackathons, what are they, connectathons? They have like a weekend connectathon before their work group meetings. I highly encourage, become a member of HL7 and go just sit in the rooms of those. You don't have to be an expert. You don't have to pretend to be an expert. People there are very friendly. They're very open, and you can ask them what may be the dumbest question in the world, and they will treat you respectfully and educate you. I've had a lot of good side conversations over the years with people just at the HL7 conferences, and yeah, they're happy to share their expertise and their knowledge. So a little bit of off the cuff plug there, but you mentioned it, and it's like I just want to
Yep.
say too that there's a key point here. Don't let this, and you've said it on keeping things manageable and small in the near term. And what I see is one of the biggest challenges. This gets very technical, very quick. Don't let your eyes glaze over because of that. If because a lot of us are quality improvement specialists. We're not computer software programmers. Take it, as you can, bite by bite. I guess that's the, how to eat an elephant. And Don, I know you don't have your screen's blurred. We don't see the elephant in the room there in the background, but how do you eat an elephant? It's one bite at a time.
That's right.
All right. Well, let me, to the last question, let me give this to Michael and let him, bring it in home. I want to see if we can have about at least 15 minutes Q&A. So we're about 1:41. So Michael, got about 4 minutes here. Bring it home for us on the audit side.
Okay, 4 minutes less. What's the question we have here? So clinical data become more significant. What can you do to make sure they're fully validated, ready to withstand the scrutiny of HEDIS compliance audit? It will go back to some of the things I mentioned earlier with, and it's actually, I will take a little bit of a moment to kind of like, I don't know, take credit or pat myself on the back, because I was really thinking about really thinking about inventories of data systems back in like 2017. And I was realizing I couldn't keep track of all this volume of documentation. So what I would have really have just liked is a standardized taxonomy of an inventory that captured administrative and clinical data, and building that out in a way that it could be more easy to maintain. And then that can attach the documentation that supports that. Because I think the direction we were going for a while as we were scaling up clinical data was just more and more Section 5s and documents that along with it. So I said, can we just get an inventory first? So that's really the foundation of it, is making sure you have a good inventory. And I think that plans have not fully leveraged that as much as they could. Metadata is just that. It's data about data. And that's what these inventories are intended to accomplish, is a one-stop shop, if you will, for how you characterize all these different channels, all these different sources, based on everything from their internal or external. Are they clinical as administrative? Are they a source from an EHR? Are they sourced from an HIE? Is there DAV certification or not? You can capture a lot of data along that way, as well as defining, like we mentioned, actually, Don gave a good example earlier of, you identify certain things that are working well already, and that's something that typically will fit into an existing use case that's well developed, like ADTs, so admit, discharge, transfers, and that's within the V2. Low latency, super quick, it's a standard format. It's not FHIR, but it's good enough. That's going to fall down in priority from my perspective and as auditor, compared to something like a manually abstracted data set into an Excel spreadsheet with no validations on it, and no controls and constraints on the fields, that's done in a very small kind of use case here or there. That's going to bubble up as important because that's got manual, it's got latency, it's retrospective. So know your data. I mean, understand, have a nice profile of your data. And again, on the platform within VLOX, it works with the audit, it's compliant with that requirement, but also captures the metadata you need to start having a future pathway to connecting with FHIR and the endpoints using the same scoring system, complexity or not complexity. So focus on that. I think also, I will take also a time to note that it was actually in 2000, just actually 2 years ago, NCQA started to require the inventory. So if you've worked with us before, worked with me before, you're set, you're in a good situation for that preparedness for your audit. But also broaden your view again. I noticed that I was asking more questions about data governance of clients, because I was starting to obsess about that. Like, I have that tendency because I started to think, okay, this is data, it's important, but we really don't know what's happening enterprise wide. That's now a part of the audit, that there's questions about your data governance program you have internally. So have something, you have at least a framework, or be working on a framework or something along those lines, so that you can start to respond to those questions correctly when you're asked about them in your audit, but also start to build on that as a foundation for your future proofing of your organization for this migration to digital quality. I also think there's a lot of things that you can be paying attention to, your own internal flags that you could be thinking about. Is this something that's going to trigger the auditor to want to look at more closely? I mentioned data sources that are manually abstracted. That's basically a given that your auditor is going to want to do some primary source verification, get some additional documentation, discuss that. I suggest you just do it preemptively. Do your own internal primary source verification, verify it against the authoritative source, the EHR, to make sure that it's matching up. And very often, if that's done in a very conscientious way and a halfway decent sample size, I probably won't even do the PSV myself. I will see that you've done the work, that you have the attention to that requirement. If you've undergone system changes or significant upgrades, if you migrated to a new vendor for, say, your HEDIS reporting, or maybe a different laboratory results vendor, if your plan has gone through a merger or an acquisition, if you've gone through a disaster, this happens, of course, in parts that have in parts of the country with hurricanes or tornadoes. If you've been hacked, and we're knowing this is a regular thing that's occurring now, you need to at least have a handle on what the scope of that impact was and what your mitigation was for it, and be sure to be able to talk to your auditor about that in particular. And then finally, I think because it's starting to come up a little bit more in discussions in the audit about what it is that's needed to prepare for digital quality measure, and I think to Reed's point and to Don's point, you don't have to be a technologist, but you shouldn't be afraid of it. You should be willing to look at an XML file and just you get them from your vendor, you get them from the IDSS. Just open it up one day and just look at it, see what it looks like, and start to get familiar with that. So that's another part that I think is important, to be able to speak to your auditor about those kind of future state questions and feel comfortable and confident when you're speaking, that you're in that same milieu and talking the same language.
Great. Appreciate that, Michael. And I'm going to hand it back to Mike Curran. We have a couple of questions in the Q&A, but let Mike, if you don't mind, kind of leading us on the Q&A. Third question came in here. Some really good questions here. But please, in the audience, feel free to go to the Q&A function and put questions in, and let me hand it to you, Mike.
Great. Thanks. Thanks, everyone. Great job. Great information across the board. And it has generated some good questions as a result. So the first one, and I'll just kind of put this out there, and it's a popular question when talking about fire adoption when it relates to the cost barrier. So how will providers with limited to no budget be able to build, implement, and maintain fire, perhaps health plan subsidizing or some incentives? So John, maybe give Michael a break and see if you have any thoughts on this.
Yeah, I'd be happy to talk about this one. Yeah, 100% a problem because many providers, and not just, especially small ones, but not just small ones, like the budgets are tight, and there's a lot going on to be able to sit back and say, all right, how do we adopt this new technology and this new standard and kind of be a driver in all this? And many of you won't be able to. So if I was a provider with limited to no budget and I wanted to at least control some of my destiny here, because one option is always to sit and wait until you're forced to do whatever you're forced to do. But I'm assuming that's not, you're asking the question, so that's probably not what you want to do. I would go and look at my existing partners right now, right? Who are you working with? Your EHR vendor. Start there. What are they doing? That's where most providers are going to get their fire functionality from, is from their existing EHR vendor. There are standards that there are things they're required to do to maintain their certifications, and they're slowly but surely adding that functionality in. So I would start there, and I would find out what are they doing, what are they supporting, what's their roadmap, and just try to understand from that. And then look at if you have other vendors. You might have some like analytics vendors that are helping you with quality measures, or any vendor that's you're working with on data. Just go talk to them, find out what their strategy is, what their roadmap is, and you can kind of start to work from there. Because if you have no budget, you're going to be limited to what you're already paying for and what is delivered through those solutions. That's where I would start. I'd say for now.
Great. Thank you, Don. Good answer. Good question. Another one, the next one, I'm going to direct this over to Michael because I think it's a bit of a continuation of what you were talking about. So Kate asks, one of the disconnects I see on the vendor side is the team at the health plan are effectively siloed from the quality team. So that's the data team and the quality team are siloed. And it's sometimes tough to get the claims, members, provider data correctly without even thinking through all the ECDS, the CT8, all the fire, all the interoperability pieces. Are there any suggestions on how to bridge those gaps? I'm sure you may have seen that in your audit travels and trying to help plans think about that.
Yeah, actually, it still is perplexing to me that when I was doing audit and I started asking about questions about fire, like this again about in 2020, that it was a different group that came in to talk about fire, and then they left, and then we were still continuing with the quality group. And I kept thinking, why are these groups not together? Why is there not at least one person from fire? And it actually did continue, I think, all the way until I did my last audit in 2024. So there is a pervasive concern there, and I think that's one thing that I tried to communicate is why are you guys not collaborating with each other on a couple of small projects, in particular, getting data out of either into or out of the fire format. I think that because of the 21st century cure and the API and the requirement for patient access API, that a lot of data actually did get from claims and those standard kind of X12 ECDI or EDI kind of formats converted through Blue Button into fire. I think the claims have been fine. That's been a very high volume in the fire stores that are already now converted into fire. But there's, depending on the region of the country you're in and the state regulations and your own in particular use cases, a lot of the clinical data does not gotten in there. So that's an area I think of common shared interest between the data team and the quality team is how do we get more of this clinical data that we both need. Your purposes be perhaps for risk adjustment, for case management, other use cases, and ours for quality reporting, HEDIS, and ultimately digital quality measurement. I think there can be overlaps there. Defining and scoring the use cases and the uses of that data, it's again something we do on the platform with VLOX. It's something that can also be leveraged by consultants like KHS and others, because there is complexity when we go from fire to a non-standard format or from a non-standard format back to fire, and not everybody's caught up to using fire as we've seen. We know that some vendors can take in a fire format and convert it for you. They may ask you to do it beforehand. So there's a lot of jumps, manipulations of the data in between the fire store that need to be addressed. And those can be, I think, ideally done through collaboration when you're focused on a key use case. And I think digital quality measurement is that key use case.
That's right. Nice
It-
read.
I'm just going to piggyback a little bit on that too, and to back to Kate's question is that, many of the engagements that we're in or have been engaged in with health plans, it is fairly common where there is the disconnect or silos between whether it's IT or data and quality. That's pretty common, and that's an area that like you said, we try to focus on and help build. Figure out how to build or break through the silo walls to do that. And then the other thing too is just kind of a little bit of a shameless plug here. So if there's anyone out there health plan wise that, if you're ever interested in doing any co-presentations at a conference with me, just on overall, these types of challenges, data governance and data strategy and other things, please shoot me a note. I'd love to have some, definitely, have some clients, but I think the more people, the more perspectives we can get those voices heard would be great. So that's my shameless plug if you ever want to join me on a conference presentation or a webinar like this. Back to you, Mike.
I want to throw one quick thing out for Kate as well on this one is my advice would be to defer the conversation about the technology as far as humanly possible when you are trying to get people on the same page of what problem you're trying to solve. And if you go back to my kind of short-term thinking, long-term thinking, short-term stuff is driven a lot by what's possible with the current technology. That is true, but you should still really clearly define the problem and what you're trying to accomplish and what the business value is prior to even worrying about it there. On the long-term side, there is no technology constraint. And if someone's telling you there's a technology constraint for something that you want to do over the course of the next 5 years, you should talk to somebody else because that's just foolish. You don't know what the technology is going to look like in 5 years. So you can only focus on where do we want to be and what problems do we want to be able to solve for our internal staff, for our internal operations, and for our members. Anything about tech in the long term is kind of silly in my opinion.
Agreed.
Mike, you're on mute.
Yeah. Thank you all. Lots of a good answer to a good question. So I'm going to go to Dawn for the final question here. Matt asks a practical question. Much of the conversation is centered around collecting data and closing data gaps, which, big pieces. But also, maybe Dawn, could you speak to some of the available resources and message types in FHIR that can actually help to close care gaps and improve outcomes?
Absolutely. So I'm so glad you asked this question, and I'm surprised it took me this far to get to this point in this conversation, is that I would say, by and large, in the wild right now, there's not a lot of things that you can do with FHIR that are going to close care gaps today. There are people who are implementing it and doing good things with it. The standards are defined and they're beautiful and they're wonderful, and there's all kinds of things we will be able to do with them. But the adoption of FHIR in production environments is still happening. That's still kind of slowly trickling out. And I spend most of my time in the HIE world, moving data all over the place, and almost none of it's FHIR. Literally close to zero. There's some in some places, but there's not a lot that you can do right now today. I think when you're thinking about new stuff that you're going to be doing over the next couple of years, you should be talking with your internal team and looking out to the community for helpers. Look to the Da Vinci project to see if there's a project they're working on that is in the space that you're trying to solve for, and you can start to look to it as a solution. But I can't point you to a specific resource or a specific measure or a specific thing that I'd say go start there, because it's just not happening yet. And it's that is, again, I said earlier, it's not a bad thing that we're taking a while to get to FHIR. It is a reality. And I'm glad I was able to make that point for you.
Yeah,
Do you
great.
mind if I add?
Great
I was
point,
going to
Dawn.
add two things real quick on that, Reed, if it's okay, if we have time.
Go for it, Mike.
Yeah. Yeah, I would say, I think that and Don mentioned the Da Vinci. If very often I think we learn something based on something we're very interested in. There are use cases defined within the Da Vinci implementation guide in the community that really address gaps in care. In fact, I see it quite often in GIC, which of course is the gaps in care in those workflows. But I also, on the flip side, I don't want to I want to caution to kind of take a wait and see role because there are several large health plans of which their names will go unmentioned, but we know who these are. They're not waiting on the sidelines for people to figure things out. They are moving full force on fire and determining it to be their best chance to have like a conformance layer. We take all this data in, we don't really care what format it is, but we're going to normalize it and match it to the FHIR schema. And from that point forward, we have multiple use cases we can use. They're not waiting. They're investing a significant amount of money. Some of them have very short timelines to get to digital quality measurement before 2030. So if that's your competitor and they have those kind of resources and they're moving that quickly, you can wait on the side a little bit, but you need to be aware that there's things happening behind the scenes that you don't want to get caught off guard on. And I think at the very least, you have to have a strategy and start building out those inventories, scoring your data, and looking where those opportunities are to start connecting to FHIR APIs for providers that are willing to do that. And they are out there. We do have clients that we've met with, and we met with other partners that are actually exchanging data for gaps in care closure. Not a lot of them, as Don said, but they are happening. And so there is precedence there.
Great.
Great.
And I'm going to slide in one more question under the wire here. I know
Oh, Mike, we got 1 minute. We got 1
But
minute.
we'll do,
Folks want to hang on.
this is going to be
We'll
a
go.
jump. This is going to be a jump ball for Michael and Don.
Oh, I went in on the jump.
All right. Do you see many health plans trying to repurpose infrastructure needed to support things like patient access API requirements with HEDIS quality measurement? Go get them. Attack.
5 seconds or less. No. Go for it.
Don, I'm going to pass to you because you guys are you're into more of the details of that. I would say no. There is patient access APIs that are available, but the use of them for HEDIS purposes is minimal.
Lightning round, Don.
Yeah, I would say I can't point to a specific example, but yeah, I mean, everyone always tries to use that existing infrastructure. And a lot of times what you end up with is an API that is new on top of an infrastructure that is old. And I would render a guess that probably is happening, but I don't have any personal experience with it.
All right. Reed, did you have a thought on this?
No, I think it's a great question, and that, just kind of recognizing, I think a lot of, with FHIR, it is built on APIs. So I think that's something that is a legitimate question or concern that we should be thinking about around the infrastructure and APIs to be able to find those synergies.
All right, great. Well, we're at time, and I want to thank everybody. I want to thank our panelists, Don Lee, Michael Campbell, and Reed Kaiser. I also like to thank Jennifer Bitterman, who has been working behind the scenes to make sure this all stays afloat. And I also want to thank the group for your attendance, for your attention, and for your great questions. And we look forward to doing this again with you all soon. Have a great afternoon and a great weekend.
Yep. Yeah, thank you all. This has been tremendous fun today. Enjoy your weekend.